Thanks the invitation from President Kirill. Presentation is to immunization. The indications for endovascular AVM embolization is curative embolization for small AVM, preoperative embolization to decrease the blood flow, radiosurgery, pre-radiosurgery embolization to targeting to the bleeding factors, and palliative embolization for large and complex AVMs. Venous approach for AVMs is only performed for selected patients. It's a small number, and its bleeding complication risk is high up to 10%. In a meta-analysis, Onyx has elevated the AVM embolization rate. And Onyx elevated the AVM complete embolization rate up to 25%. The preoperative AVM embolization only gave a low complication, complete occlusion rate. And the complete occlusion rate is also low in high-grade SM AVM high-grade Spezia-Martin grade 4 and 5 AVMs. With the development of AVM embolization techniques, the curative embolization has been elevated. But the main problem associated with AVM embolization is the periprocedural bleeding complications. The bleeding complications related to AVM embolization is high up to 8% in pre-radiosurgery embolization and Onyx embolization. The mean periprocedural bleeding complication rate is 5%, and the mortality of bleeding complication is 31%. AVM embolization has caused contradictions in AVM outcomes. In some literature, AVM embolization has lowered AVM bleeding complication risk. In some literature, the bleeding risk did not change. And in some literatures, the AVM bleeding risk has been high because of different AVM embolization indications and techniques. Bleeding complications caused by AVM embolization is vessel-perforated aneurysm rupture, Nados damage, premature vein occlusion, and catheter capture. In 2 studies, Onyx bleeding risk associated with Onyx embolization is a higher amount of Onyx precession, premature venous occlusion, and Onyx volume. The proportion of Onyx volume and Nados diameter. In one theoretical study, the Onyx volume is associated with injection pressure, diameter of the catheter, and injection time. Therefore, if we want to decrease the Onyx volume, we need to decrease the injection pressure and injecting time. With the techniques development, the bleeding complications associated with AVM embolization did not decrease. The new techniques, including multiple catheter technique, hyperpressure technique, double catheter technique, and tip detachable catheters, because these techniques did not overcome the bleeding risk factors, over volume of onyx injection, and premature vein occlusion. Multiple sessions can decrease the bleeding complication rate and also elevate complication obliteration rate. Partial embolized AVM, the bleeding risk is 1 to 2%. We have changed the proximal plug technique for AVM embolization and promote antegrade drifting technique for AVM embolization. The AVM the angiographic architecture of AVMs is included 5 parts. The first is arterial venous shunt, arterial suppliers, arterial venous shunts, and the nidus. The nidus is there are a big amount of aneurysms and aneurysmatic bulgings on the nidal venules. Communicating veins. The communicating veins is between AVM nidus and the normal parenchymal and the draining vein. Here is a super selected macrocatheter angiogram showing the arterial venous shunt. The injection reflex weight injection technique can usually cause premature vein occlusion. This picture shows the onyx only occluded the vein, then it will come to the other parts of suppliers. We have provided a radio clinical grading system for transartery AVM embolization. I call it Tsinghua AVM grading system. This grading system included AVM presentation, rupture or unrupture, AVM location, superficial or deep, AVM size, small and large, coexisting arterial aneurysm, yes or no, high flow fistula compartment, yes or no. The Tsinghua AVM grading system can predict the complete AVM occlusion as well as Buffalo grading system. This is the AOC curve for comparison of Tsinghua and Buffalo system. But it is interestingly, the Tsinghua AVM scale also correlates with pre-MRS, the patient's status at presentation, and onyx volume. But Buffalo did not correlate these factors. Our updated onyx embolization for AVMs has elevated the complete occlusion rate from 25% to 50%, and the bleeding complication risk has decreased to 2%. This is a bleeding AVM. Angiogram showing a parietal AVM. Two catheterizations of the feeding vessels and complete occlusion this AVM. Here is the cerebellar AVM and complete occlusion with onyx. This is the temporal AVM, also complete occluded with onyx. Here is AVM of anterior choroidal artery. and completely embolized with onyx. This is an AVM of anterior choroidal artery embolized with onyx. This is a AVM of anterior choroidal artery after surgery resection, and completely embolized. Here is a brainstem AVM and completely occluded with onyx. This is a superior cerebral artery AVM and also complete occluded with onyx. Here is a small AVM of the periclossal. The patient presented with intraventricular hemorrhage, and AVM was completely occluded with onyx. This patient presented with 2 AVM needles. The patient, the thalamus AVM is the bleeding lesion. Therefore, we embolized the thalamus AVM. This is thalamus AVM and also complete occluded with onyx. This is a residual AVM after surgery. The vessel perforation developed while we advanced the metal catheter to this curve, and onyx was injected, but the patient did not develop the new neurological deficits. This is the residual AVM after surgery, complete with onyx. This is another AVM after surgery, also complete occluded with onyx. This is the frontal AVM and complete onyx embolization. This is a small AVM of the anterior cerebral artery and completely occluded with onyx. This is a complicated case. The left transverse sinus is thrombosed, and the right transverse sinus is stenosis. First, we give the right transverse sinus a balloon dilation and put a stent. Then we embolize the AVM. After embolization, the AVM is nearly completely occluded. The deep, small, and residual AVMs, we can achieve complete obliteration with endovascular embolization. Sonics and Apollo detachable catheters did not decrease the bleeding complication risk because the bleeding complications caused by catheter capture is low. Over embolization with onyx and premature venous occlusion is a bleeding risk for AVM embolization. Multiple catheterization can provide a high AVM obliteration rate and decrease the bleeding risk. Radiosurgery, pre-radial surgery is associated high should be targeted to the bleeding risk factors. Should not be the volume shrinkage. Thanks.